Hello. So, in this discussion, we are going to talk about acute leukemia. So, now there's been presentations on overview of hematopoiesis, and these presentations, they're about three. They've been talking about what this process of hematopoiesis is all about, which is basically a process that involves the production, differentiation, maturation, development of the different types of blood cells that we have. Yeah. And with that overview, I went ahead and talked about how certain hematological disorders would come about by affecting certain components that are involved, or rather cardinal, during that process of hematopoiesis. This is why we talked of if there is any changes or rather disruption in the stroma that forms that environment suitable for hematopoiesis, a problem would come in. If there's a problem affecting the stem cells, again this process would be affected, and other things that are needed, such as nutrients, those other supportive kind of structure. Yeah. The kind of chemicals that stimulate the process, such as erythropoietin and all that, and problems would come in when there's a problem with that. Now, another form of hematological disorders are the malignancies that are associated with hematological disorders, or the malignant or neoplastic kind of hematological disorders. So today we'll look at one of those neoplastic kind of hematological disorder, and this is acute leukemia. However, as we dive into the discussion of acute leukemia, we are not again going to talk about the specific subtypes in details, but rather we are going to look at the nitty gritties, what is very important to understand when you hear acute leukemia. This is something that will help both clinically and even for students to have an easy understanding of what acute leukemias are all about. I believe with an understanding on how to approach them clearly, it becomes easy to add in some of the specific details you may have with a particular subtype. Yeah, because then you even know how it comes about and where to put it. Okay, so now we proceed into acute leukemia. So now, before we even go to the definition and the other details, I would like to briefly mention the same process of hematopoiesis, which you can also find in the overviews if you need a further understanding on that. But here I'll just look at the framework, because it is from there where we'll get the understanding on how this abnormality comes about, or rather how this neoplastic change comes about. So now, hematopoiesis begins with the hematopoietic stem cell, which is a pluripotent stem cell within the bone marrow. So now this pluripotent stem cell, which we are calling the hematopoietic stem cell, which is a CD34 positive kind of stem cell, it will differentiate into two different type of progenitor cells. And these two main different types of progenitor cells, or rather two different types of stem cells, are the two main stem cells that gives rise to the two separate lineage of blood cells. And it is important that you follow this from here. So the first stem cell that will arise from this pluripotent hematopoietic stem cell is called the myeloid stem cell, which would also be referred to as a myeloid blast. Okay, the other stem cell that will arise from this same hematopoietic stem cell is called the lymphoid stem cell. Okay, these progenitor cells, which begin this cascade of differentiation until you have those mature cells, they're the ones that form the two divided lineages, the two main categories that you have of blood cells. Okay, So now, the lymphoid stem cell is the one that will later on give rise to lymphocytes. Yeah, the B cells, the T cells, yeah, the CD4 T cells, the CD8 T cells, all that from the lymphoid stem cell. From the myeloid stem cell, this is where we'll get the cells such as the erythrocytes, the monocytes, the granulocytes, and the platelets. Okay, so now from the myeloid stem cell, you get blast cells. Yeah, and these blast cells include the erythroblast, yeah, the monoblast, the myeloblast, as well as the megakaryoblast. The erythroblast will give rise to erythrocytes. The myeloblast will give rise to granulocytes, neutrophils, eosinophils, basophils. The monoblast will give rise to monocytes. The megakaryoblast will give rise to thrombocytes, the platelets. Okay. On the other hand of the lymphoid stem cell, the B lymphoblast will give rise to the B cells, the naive B cells, which when later on become activated to produce antibodies, they will become plasma cells. The T lymphoblast will give rise to naive T cells, which will later on differentiate into either CD4 positive T cells or CD8 positive T cells. Okay. With that understanding, when we talk of acute leukemia, this is a process where the blast cells, those progenitor blast cells, yeah, which is the either the myeloid stem cell itself or the lymphoid stem cell itself or the precursor blast cells such as the monoblast, the megacardioblast, or the erythroblast that will become defective in a way that they don't undergo a proper differentiation to differentiate into mature cell type, and they will begin to divide and increase in their immature state like that, giving rise to bringing about an increase in the number of immature cells within the blood. And these immature cells can be detected when you do a blood smear. Okay. And this is where now our discussion of acute leukemias come from. With that, by definition, acute leukemia will be defined as a neoplastic accumulation of blast cells in the blood. When I say neoplastic accumulation of blast cells in the blood, we know that this is a cancerous process in the sense that this immature differentiation of the blast cells is happening in an uncoordinated manner and in an irreversible manner. Okay. It is, of course, neoplastic. Yeah, so with the understanding of neoplasia generally, of which I'll see if I can do a separate presentation on the general principles to know about neoplasia. So that's what this is about. And now we have an understanding of what blast cells are. Okay. With that being said, it is important to further understand to say this neoplastic accumulation of blast cells in the blood within the bone marrow, the blast cells are greater than 20% for you to say now that this is acute leukemia. Why is it important to know that the blast cells should be greater than 20% in the bone marrow for you to say that this neoplastic accumulation of blast cells is acute leukemia? Because there's another disorder, and this disorder is called myelodysplastic syndrome. So in myelodysplastic syndrome, just like in acute leukemia, you get the cytopenias, yeah, And these cytopenias that you get, which I'll talk about under acute leukemia, they will be associated with a hypercellular bone marrow. This hypercellular bone marrow is as a result of abnormal maturation and increase of blast cells. But these abnormally blast cells that are accumulating within this bone marrow are of less than 20%. That is why it is important to know that the blast cells are of greater than 20% in the bone marrow when you talk of neoplastic accumulation of blast cells in the bone marrow in acute leukemia, because it helps to differentiate it from myelodysplastic syndrome. Okay. With that being said, we move on. With the understanding to say acute leukemia is a process where you have these blast cells that are not undergoing proper maturation into mature cells, and they are dividing like that abnormally, leading to that accumulation of blast cells. The next question we will ask ourselves is, how does this bring a problem? So I thought of bringing this here because we won't like touch those individual part, but because we are intellect medicals, and as intellect medicals we advise to think outside the box and to not master things, but rather have an umbrella understanding of how certain things come about, and this is how we approach these features under acute leukemia. So the increase in the blast cells within the bone marrow will disrupt the normal hemopoiesis because they are now overcrowding this stroma that is needed for a normal hematopoietic process to take place. So due to that overcrowding of normal hemopoiesis, you end up having a decline in the number of other blood cell types. And this would present with anemia, neutropenia, and thrombocytopenia. And those are the cytopenias that I talked about when I was describing myelodysplastic disorder. So this is someone who present with the signs and symptoms that you expect to see in someone with anemia. Okay, and this will be someone who will come again and will present with the neutropenia. Okay, now neutropenia, you might be wondering to say, how would I know? Of course, CBC would help, but then clinically, this is someone maybe who be coming with recurrent infections, fevers, and all that. You do full blood count, you find that they are neutropenic actually. You do further digging, blood smears are done and all that, you discover that there are actually even some blast cells that are present within the blood, yeah, until you come to a point where you even diagnose an acute leukemia, such kind of thinking. Okay, so these are people come with fevers and signs and symptoms signifying an infection. Okay, neutropenia. Thrombocytopenia, this is someone who would present with a bleeding diaphysis, where they are bleeding from orifices, or maybe they're having difficulties in clot formation, where when there's a wound, it bleeds for a long period of time, and then you discover that they are actually thrombocytopenic. Yeah, so that's the general understanding about features. When we come to the classification, okay, so the classification of acute leukemia, it is based on the lineage of cells which are affected. And this is the reason why I had to walk us through the hematopoiesis process. And this is why I had to mention the two main division, the two main cell lineage. So now, with that understanding of the myeloid lineage and the lymphoid lineage, as was described earlier, classification of acute leukemia would be acute myeloid leukemia from the myeloid lineage, or acute lymphoblastic leukemia from the lymphoid lineage. Meaning in acute myeloid leukemia, the problem is with the blast cells of the myeloid lineage. In acute lymphoblastic leukemia, the problem is with the blast cells, those mature dividing cells of the lymphoid lineage. Okay. Now, the next question we'll ask ourselves, because these are immature cells, these are blast cells, how do we differentiate to say this is from the myeloid lineage and this is from the lymphoid lineage, for us to be able to tell that this is acute myeloid leukemia and this is acute lymphoblastic leukemia? Well, this differentiation will be based on the phenotype of the cells. With that being said, I want you to understand to say in acute myeloid leukemia, the myeloblast, okay, or rather the myeloid stem cells or the myeloid blast cells, they possess myeloperoxidase. Yeah? So this myeloperoxidase, you can't find it, one, in mature cells from the myeloid lineage, and you can't find it in immature cells of the lymphoid lineage and mature cells of the lymphoid lineage. You see? So they are special to the immature cells of the myeloid lineage. So this same myeloperoxidase can be detected by stains. Special stains can be used to detect the presence of myeloperoxidase. And you will say, okay, this blast cell is of the myeloid lineage. Yeah? The other way is that this same myeloperoxidase has the propensity to form aggregate crystals, and these crystals can also be seen, and they are referred to as an aura rod. Okay, so the presence of these aura rod, which are just aggregates of the myeloperoxidase, can also be seen with special stains and would be used to diagnose acute myeloid leukemia. Okay, when we come to acute lymphoblastic leukemia, the phenotype marker that is used to diagnose it is actually the presence of TDT DNA polymerase. Okay, so these cells will be TDT positive. And this TDT is a DNA polymerase, which is important to understand. This, again, you want to find it in cells from the myeloid lineage, and you want to find it in mature cells of the lymphoid lineage. Okay, so that's how you come about with the classification. When we move on to subclasses of these two individual types that we've come up with, the AML, which is the acute myeloid leukemia, and the ALL, which is the acute lymphoblastic leukemia. These two main types have subtypes, they have subclasses. Okay, so now we are looking at the subclasses of ALL. ALL, if you remember from our brief talk about hematopoiesis, we said from the lymphoid lineage, we get the B lymphoblast and the T lymphoblast. And these will give rise to different types of mature lymphocytes. Okay. With that same statement, yeah, or with respect to that same understanding of the two different divisions that are there, we can further classify acute lymphoblastic leukemia as the B cell type acute lymphoblastic leukemia or the T cell type acute lymphoblastic leukemia. Yeah? And it is important to understand that the BALL or the B cell acute lymphoblastic leukemia is more common compared to the T cell acute lymphoblastic leukemia. Okay, now the next understanding that we need to have again is how do we subclassify them? If we have identified to say, okay, because this blast cell is TDT positive, and we are saying it is acute lymphoblastic leukemia, then how do we tell to say this is a B cell acute lymphoblastic leukemia or a T cell acute lymphoblastic leukemia? Well, this classification will be based on the surface markers that you find on these cells. So the B cell type of acute lymphoblastic leukemia, the surface markers that you find are CD10, CD19, and CD20. Okay? Wow. The surface markers that you find on the T cell acute lymphoblastic leukemia are the CD2 to CD8. There won't be any CD10 surface marker on a TALL. Okay, so that is important to understand. Remember, surface markers are used to differentiate them, and we also have to know from here to say the BALL or the B cell type of acute lymphoblastic leukemia is more common. Okay, then from there, what else are we supposed to know basically about this condition? Well, the BALL being the common type, it is important to understand to say generally it has actually a good prognosis to chemotherapy. Yeah. And specifically, the prognosis will be determined by the cytogenetic abnormality that is involved. Okay, so commonly the BALL, the cytogenetic abnormality that is involved is the translocation 1221, and this is common in children and it has a good prognosis. However, in certain types of BALL, you might have a translocation of 922. Remember the Philadelphia chromosome. So these ones will have a positive Philadelphia chromosome, which we normally expect to find in CML, yeah, the chronic myeloid leukemia. Okay. And these have a poor prognosis. That's important to understand. They have a poor prognosis and usually present in adults. Okay. So, with that understanding, we can now move on to the other aspect of TALL, because we've described BALL in details, but now we also have to understand something about TALL in details. Okay, so commonly, like I've already mentioned, to say the the cell surface marker involved will be CD2 to CD8. The other thing that is worth mentioning again might be that in most cases, TALL will present in teenagers, and this is a teenager who have a mediastinal thymic mass. Okay, remember that the premature T cells will undergo maturation within the thymus. So you expect to find more of these T cell immature blast cells in the thymus. And now, because they can lead to the formation of a thymic mass, this type of TALL will be described as acute lymphoblastic lymphoma. So when you see acute lymphoblastic lymphoma, just know that they are referring to a T cell type of acute lymphoblastic leukemia, which has presented with abnormal accumulation of blast cells within the thymus, presenting with a thymic mass, which will be a mediastinal mass, and very common in teenagers. That's the basic understanding that is worth mentioning about this TALL. Okay, now we move on to the subclassification of AML, acute myeloid leukemia. So its classification is actually based on three aspects. The first one, it will be based on the cytogenetic abnormality involved. The second one used is based on the lineage of the myeloblast. And the third one is the surface marker. So here I will specifically focus on the classification based on cytogenetic abnormalities and the cytogenetic, I will focus on the classification based on the cytogenetic abnormality and that one which is based on the lineage of the myeloblast. Okay. So based on the cytogenetic abnormality, here we are just talking about what kind of translocation is involved in this disorder. Okay, so the commonest one that you come across is the translocation 1517, and this is also called as acute promyelocytic leukemia. Well, like I had said, I'll mention some types, but we won't go into details into these other types. But worth mentioning about this acute promyelocytic leukemia, which is associated with translocation 1517, is that it is as a result of a disrupted retinoic receptors. Okay, so there is disruption of retinoic receptors, and now these retinoic receptors are essential in helping promyelocytes to mature into mature myelocytic cells. Okay, now with this disruption you end up having immature promyelocytes accumulating, and these will contain aura rods within them. Now the other risk factor that is associated with this condition is that the aura rods that are present within the immature promyelocytes are actually capable of activating the coag cascade, and this might later on present with disseminated intravascular coagulation, DIC. Okay, and the management is actually based on giving an agent that stabilizes this retinoic acid receptor so that the immature promyelocytes can later mature and become mature myelocytic cells. And the commonly used agent is all-trans-retinoic acid, which stabilizes this retinoic acid receptor so that immature promyelocytes can undergo maturation. That's something worth mentioning about the acute promyelocytic leukemia. So that was under cytogenetic abnormalities that you would be able to identify. Subtypes of acute myeloid leukemia based on the type of cytogenetic abnormality that is involved. So we check the blast cell, we find, okay, it is MPO positive, this myeloperoxidase, or we've seen the aura rods. Then next, after carrying out some cytogenetic assessment, we find that the cytogenetic abnormality involved in this same cell is translocation 1517. Then we say, okay, this is a AML, and now there's a translocation 1517, so this is acute promyelocytic leukemia. Okay, the other aspect that will be used to subclassify AML is the lineage of the myeloblasts that are involved. This is common, and in most literatures you find this being talked about frequently. This one will now take us back again to that hematopoiesis overview that we had brought in the beginning. So remember when I said from the myeloid lineage, where we have the myeloid stem cell, we can either have the erythroblast, the monoblast, the megakaryoblast, and the myeloblast. Okay, so now when you subclassify AML based on the lineage of the myeloblast that is involved, this means now you will be classifying AML by saying, is it a defect with the erythroblast? And this will be acute erythroblastic leukemia. Is this AML where we have an issue with the blast cells, specifically the monoblast? Then we will have acute monoblastic type of leukemia. Okay, is this the type of AML where the blast cell affected is that of the megakaryoblast? And this is where we have a leukemia such as acute megakardioblastic leukemia. Yeah. So with those examples being mentioned, maybe just to say one or two things. The acute monocytic leukemia, where the problem is with the monoblast, will usually present with gum infiltration, where there will be a swelling of the gingiva, yeah, and this usually lacks myeloid peroxidase. Okay, that's worth mentioning, because under the subtype, the discussion, you discover to say actually people with AML might present with gum infiltration, and it is important to maybe mention which type specifically you would commonly find that. Okay, so that is it about the acute monocytic leukemia type. Okay, so with that being mentioned, this has now actually brought us to the end of the discussion. But as usual, before I conclude, I'll just briefly talk about the overview of what we've discussed so far. So we are looking at acute leukemia. And acute leukemia, we are saying this is a neoplastic accumulation of blast cells. By saying it is the accumulation of a neoplastic accumulation of blast cells, we went ahead and said, what are these blast cells? So we discovered to say these blast cells are those immature cells that are still undergoing division into becoming those mature blood cells. And these could be of the two main lineages. They could be from the lymphoid lineage, they could be from the myeloid lineage. And acute leukemia will be defined as such if the presence of these blast cells within the bone marrow is of greater than 20%. And we further went on by classifying this same acute leukemia by saying, because it could arise from the two main lineages that are there, so it can be acute myeloid leukemia involving blast cells of the myeloid lineage, or acute lymphoblastic leukemia involving blast cells of the lymphoid lineage. And this classification will say it will be done based on the phenotype of this blast cell. Okay, the next thing that we mentioned is that the two main types can be further subclassified based on the surface markers. Okay, and when you subclassify them, you will have, on the other hand of acute lymphoblastic leukemia, you have what we call the BALL and the TALL, based on those two main division of the lymphoid lineage, which is the B cells and the T cells. And we said the BALL is the common subtype. And we said the surface markers you'll find are the CD10, CD19, and CD20. While on the TALL, the surface markers involved are the CD2 to 8. Okay, we went ahead and subclassified acute myeloid leukemia based on cytogenetic abnormality involved and the lineage of the myeloblast involved. Is it the monoblast? Is it the erythroblast? Is it the megakaryoblast? Okay. Worth mentioning is that because there's this abnormal accumulation of blast cells within the bone marrow, these blast cells would leak into the blood, and they will show leukocytosis, which will be of immature cells. And when a blood smear is done, these immature blast cells will be seen, where they will be larger than the normal cells. And if it's the red blood cells, they will possess the nucleoli. And typically, these nucleoli will have it will be like a punched out kind of nucleoli. It will be showing areas where like the nucleoli was eaten up, yeah, within that cell, and the presence of the aura rod would be seen in cases of acute leukemias of the myeloid lineage. Okay. So basically, this brings us to the end of this discussion. I hope you find this useful. Looking forward to creating more presentations when I find time. Thank you for your time. Stay blessed.